One of the first questions that's come up for our newly diagnosed patients, how important is it that they seek a second opinion? Many of them are afraid to do so.
Unfortunately, juvenile myositis is a long-standing condition, and the person you're going to be working with, it will be a long-term relationship. And the idea of being afraid to get a second opinion, I'm not sure what that means, if you're afraid that you're going to offend the clinician that you're getting a second opinion or something like that. But I think that try to get away from that fear, and I think if there is concern, getting a second opinion is an excellent idea. And I think we've all seen second opinions, and then they've gone back to their regular rheumatologists, and we've partnered with other rheumatologists to help them in patients' care and things like that. And oftentimes, care offered by the local rheumatologist has mirrored what we would do as well. So I think that just offers another layer of reassurance. So I would say, don't be afraid, get a second opinion. I don't think your rheumatologist will be offended by that.
Okay. I just also want to say that because the disease is rare, that it's just important that you're working with a doctor that feels comfortable to ask the experts, and if it can't be that you can go see the expert, that they can call the expert or email the expert and get some other inputs. And there are several experts, so it doesn't have to be from one person, but that they're comfortable seeking out other thoughts in the care and translate that to care for your child. And that can be at different points. This doesn't always just come up at diagnosis. There are other sometimes critical points in the treatment that you need that input.
Okay, we are bombarded with information about different diets, paleo, autoimmune, gluten-free, dairy-free. It can all be very confusing. Are there any diet recommendations that you have to optimize quality of life for our JMers?
First of all, there is emerging data with other autoimmune diseases about some things in the diet that could trigger more inflammation. These things include things like red meat, sugary beverages like sugared sodas, high salt. These are things that somehow stimulate the immune system and the inflammation pathways, if you will. We're also learning that some conditions are improved by what we call the Mediterranean diet, things that include high vegetables, high olives or olive oil, a lot of fish, a lot of omega-3s that we find in salmon. That type of diet could be helpful. We have no data in myositis that these type of changes to diet would be helpful, but just in extrapolation from these other conditions where like rheumatoid arthritis or asthma, where data is starting to emerge that it might be. We don't know. A lot of people are very fearful about gluten in their diet. Certainly some patients do truly have a gluten insensitivity because they share the HLA genes with the same genes that are involved with gluten sensitivity. This can be tested. Often there's a family history, so often this is in your family. There are often a lot of GI symptoms, abdominal pain, diarrhea. Certainly that's even worse after you eat these products that contain gluten like pasta and things like that. But your doctor can specifically test because a lot of patients go through the labor of really eliminating gluten and it may or may not be very helpful for them. And just the last thing is that a high salt intake and high sugar intake just could make some of the weight gain and bloating that occurs with prednisone just that much worse.
Maybe just to emphasize also the microbiome in that context, because the microbiome is affected in a major way by the diet and can have significant impact, not necessarily in terms of causing the disease, but in terms of modifying the severity of the disease and flares. This is very well known across multiple of the other autoimmune diseases. So very likely to be the case in JM.
Yeah, we don't yet have data on that in JM, I just want to say, but from extrapolation it might be.
So many of our patients receive physical therapy as part of their treatment regime. What role does exercise play in treating and supporting JM care?
There just have been a number of studies that have shown us that exercise is safe and that patients who are getting exercise would have a better outcome with their quality of life and their function, physical function. And there are different types of exercises. We know many patients develop joint contractures from the muscle weakness. So they need stretching exercises. Other patients need specific exercises to strengthen the muscles, but that has to be done in a graded and safe way. And then others need endurance building exercises. And we really do have learned from Dr. Feldman's and others' work that there really is some deficit with that endurance and energy metabolism, and that really we hope that exercise can build that back. There's some studies that suggest that's improved in the muscle with exercise.
Why are there not a lot of great treatments for lipodystrophy? Is this on? Okay, sorry. And are there any promising treatments around the corner?
Lipodystrophy is a loss of body fat. It occurs rarely, maybe under 10% of children might develop this complication. It occurs later, several years into disease. It might be the result of prior inflammation in the fat tissue. It looks like in some patients that might be the case. So it has sequelae from that when you lose your fat really is part of your whole metabolic system. It helps you digest sugars. It helps you digest other fats like lipids or cholesterol. So when we lose fat tissue, then we don't have a place to store those things away and metabolize them properly. And so people can get an abnormality in their whole metabolism the more fat they lose. So it's not just a cosmetic issue of trying to reimplant fat or other types of implants to make the appearance better, but also fixing the metabolism. There is one treatment that's been developed at the NIH called leptin therapy. This was developed for patients with very severe form called total generalized lipodystrophy who have specific mutation in this particular gene, and they can have a replacement therapy. And this group at the NIH and the Diabetes Institute has also taken some patients with an active JDM. And actually, there's a group at University of Michigan who, Dr. Oral, who started at the NIH, she's also taken some patients with JDM and tried to give them this leptin replacement therapy. And it's worked when the JDM is less active. It helps to restore that metabolism. But it's not for every patient because not every patient has that deficiency. But new treatments, I think, will be worked on by the people who study lipodystrophy.
Will the samples and information collected today for the CHOP folks also be included in the CARRA registry?
We will have every intention to have them there as well, yes.
Okay, and if folks in the room want to be a part of the CARRA registry?
You could actually log on to the CARRA website and see if your clinician is part of the CARRA registry system. As I mentioned earlier, right now the patients we're enrolling into the CARRA registry are only the new onset patients, and not all of the patients. Previously, we had enrolled over 700 patients with at all different time periods with JM. But unfortunately, right now we're limited to just the new onset patients for patients who have been treated for under 12 weeks. But hopefully that will expand over time. But I would encourage you to ask your pediatric rheumatologist if they're a CARRA center, and when you go back and see them for subsequent visits, if things have changed, if you are able to enroll your child into the registry. I'd also encourage you to look at the website that also shows you where the CARRA centers are too. So,
do autoantibodies that are present, MSAs, change over time? So is there any benefit to having the testing done when you're first diagnosed and then having it done as your disease progresses or changes?
We've not looked at immunoprecipitation at different time points. But I don't think we would expect the autoantibodies to change over time. So we know that when autoantibodies occur, they tend to occur on their own. Patients don't have multiple autoantibodies, and actually that can be a sign that you've got a funny test result if it's coming back with more than one autoantibody. We have done some work looking at autoantibody titer, so the level of autoantibody over time, and that does seem to go up and down for the antibodies that we've looked at. So some patients who are autoantibody positive at the beginning may become autoantibody negative. We think that probably reflects disease activity, but the numbers that we've been able to look at are very small. But we wouldn't expect you to develop a different autoantibody over time, although I don't think we necessarily have the research to prove that.
Is there any concern with prolonged IVIG use? Many of our patients have been on IVIG therapy for several years.
Also that from Dr. Brian Feldman's work, we understand that patients could receive IVIG for several years and continue to improve out from there. That's a little bit different than adult patients with dermatomyositis, where there was a study that supported using it for a short term, like 6 months. So some doctors tend to stop it at 6 months because of the adult experience. Adults also more commonly seem to develop a tachyphylaxis. That means that they don't respond as well to the treatment over time. I don't think we see this problem as often in the children.
I'll just make a quick comment. Seeing adult patients, actually, I haven't seen a lot of like tachyphylaxis, what you're talking about, but I think all of our patients do really well on long-term IVIG. I have some patients who can only take IVIG because they've had severe transverse myelitis from herpes zoster. So I have some patients on it for 10 years and they're doing fine. So I think it's not ideal to be on a drug that long if your child transitions to an adulthood, but we also have patients who are on it doing very well.
Okay, and lastly, what is the biggest, most exciting advancement in JM research and or treatment since Cure JM was formed or since you joined our organization?
I think you guys see it here today with all of the speakers that have been here, just the amazing partnering of all the efforts with CARRA, with CHOP, with the UK. It's just all amazing, and I think it's really brought us much further along in trying to figure out how to care for JM better. But it's just amazing. Like, people are from everywhere to help solve this puzzle. So thanks, Cure JM.